How did you actually learn EKG?
So my father-in-law is an internist, so I spent some time with him learning them. I
Okay.
shadowed a bunch of cardiologists, so I've had a lot of practice with them. Now, of course, I'm not an expert, so I just need to come out and say that, obviously.
I couldn't tell.
Pretty close.
Like,
Listen, if we fail, I'm blaming all on you.
All right, so let's see.
Wait, is there any way you can share the slides with us?
Yeah, that's what I'm about to do first. I wanted to make sure that I hit record. It says that I'm recording. So
Yeah, you are.
Yeah.
All right, let me do slideshow mode. All right, so EKGs had me like, I'm sure that's how everybody's feeling right now, right? By the end of the lecture, my goal is to have everybody tell me, or at least be able to understand, a couple of things that are going on. Because yes, there's a lot, but we're going to go over the major points. So the first thing that we need to know about this is that we're dealing with depolarizations and repolarizations both towards and away from a positive electrode. The easiest way to think about this is that the positive electrode is sort of down in the lower inferior portion of the heart, okay? So basic principles, when we have a depolarization going towards the positive electrode, that's going to give us a positive deflection on the EKG. When we have the depolarization moving away from the positive electrode, that's going to give us a negative deflection. So that's why you see some of the waves going down. When we have a repolarization, it's going to be the complete opposite. So if we have a repolarization towards a positive electrode, that gives us a negative deflection. And if we have a repolarization moving towards that, that's going to give us a positive deflection. It's kind of like, I think somebody made an analogy with sound. It might have been the Boards and Beyond video. But if you're moving towards, or if a sound is moving towards you, you're going to hear it louder than, say, somebody if the sound is moving away from them. And that's basically the principle behind this. So keep all of that in mind. As it comes to the leads, this is where it gets crazy, right? Because a lot of people, they don't think about this appropriately. But each one of these leads gives us some new information or some more information about a particular location on the chest. So starting with lead one goes from the right upper extremity over to the left upper extremity. So if you remember what I just said, that we're thinking of the positive activity or the positive electricity moving from right to left and basically slanted down into the left inferior border of the chest, then lead one should be positive because the depolarization is moving along that leftwards vector. Is everybody good with that?
Yeah.
Following it left. So then lead two goes from the right upper extremity down to the left lower portion of the chest. So very similar to lead one, because we're moving to the left, and actually because we're also moving down, lead two should be extremely positive if everything is correct, okay? So it's literally riding that depolarization down into the left lower quadrant or whatever you want to call it of the chest.
I got a question for you. Just why do you get like the Q like dip then in that case? Is that like a split second of the depolarization moving like the other way or?
Exactly. We're going to get into that in a second. Exactly. Good question. The net effect, right? The net effect of the QRS is that we see mostly positive.
Right.
Okay. But that's a really good question. For lead three goes from the left upper down to the left lower. So again, because we're riding that left, it's going to show a net positive deflection upwards. Okay. And remember, we're just basically talking about the QRS in this case, because that's the most prominent wave and that's the easiest one to see. When it comes to AVF, AVL, and AVR, the way that I like to think of these, AVF, the F stands for the floor. The AVL, you could think of the L as standing for lateral or left, and the AVR is standing for the right, okay? So as we can see here, the AVF is moving down towards the floor or down towards your foot. So if we're consistent in explaining this, since we are going down, AVF should be positive, okay? Because it's still heading downwards on that depolarization heading downwards. AVL is going to the left, but we will see some variation in AVL, okay? I have to say that. And, we may see some variation in all of these leads, but typically AVL is going to be either positive, or we call this net zero, somewhere in between, okay? This one's a little bit shaky. As for AVR, AVR should not be shaky. AVR is going to the right. So it's moving in the complete opposite direction to the electrical activity of the heart, okay? And that's why this deflection here is negative. Remember, these leads show the electrical activity with respect to different locations on the chest. And that's how you guys have to start thinking about this, okay?
So what would be like an easy way to like summarize that? Would you say whenever the heart beats for like AVL, let's say, does that mean that it's going towards the left side, and it'll be like, is AVL looking at the left side of the heart is what I'm trying to ask?
Yes, yes, because it's the augmented lead, and as you can see in the picture here, it's going towards the left extremity. So, you know, AVL should, in theory, be very positive. It just, in this case, the slide doesn't really show that. But again, there's going to be variations, okay? So it's the kind of thing where you have to look at each lead individually, but then you look at all of them together to get the big picture, if that makes sense.
Yeah.
In Ninja Nerd, the video that they posted, I don't know if anybody watched that, but I didn't have a life, so I watched it. And that's actually really, really good. And what they did for this was like, so think of the positive sign as pretty much your eye. That's the direction from which you're looking at it. So it's like if you're talking about AVR, you see how the positive node there, like that's the direction from which you're looking at it. So you're looking at just the right side of the heart from the right side. Does that make sense? And AVL, you're looking at from that left upper side. AVF, you're looking at it from the floor.
So if you're looking at it from the plus side and it ticks up, that means that the current is coming towards you.
Yes, exactly. Like just like your eye, right? Like the light has to go into your eye. So wherever you are, wherever the rays are pointing towards you, that's going to be the direction you're looking.
All right, thanks, fellas.
The only exception to that is AVR, though, because if you look, the leads are actually switched for AVR.
Oh,
right? Because the positive is on the other arm. So that one's very confusing. That's why I'm just trying to make this as simple as possible with the overall directions. But you are right, Haas. That is a good way of looking at it, except for AVR.
There's only one thing we need to know for AVR, though, right? It's like the left coronary block or something, like acute. What am I call it? Did you guys see that?
Which one?
On BNB, they said it's like the forgotten lead, AVR, and they're like the only time that you ever see anything abnormal, and that is whenever you have like the left coronary artery that's blocked. You know how the left coronary artery comes out like real quick and then it splits?
Mm-hmm.
Right where it comes out, if you have a block there, you'll actually see activity on the AVR.
Oh, okay.
That's the only time we need to like remember it.
Is the reason why AVR is pointing downward is because it's like the depolarization is away from it?
Yeah, because it's going away from the normal vector, right? The normal direction of the depolarization. AVR is very confusing. That's why I just like to think of it as normally going downwards and kind of moving on from there, you know, because there's so much other stuff that we got to know. So if you see AVR going down, then, you know, it's basically where it should be. Okay. So then we can start talking about the mean electrical axis. So the mean electrical axis is pretty important. In the lecture, she kind of like didn't make it seem like it was that important, but it actually gives us some really good information. It could tell us about the orientation of the heart. Basically, like if the depolarization is going in one particular direction or not. It could tell us whether there's ventricular hypertrophy, which we're going to see a little bit later. And also it can tell us if we have any bundle branch blocks, or imply if we have any bundle branch blocks. So this picture here is very important. It shows the leads and it shows the angles as to which direction these leads are going. So because she didn't really spend too much time on this, I'm not going to spend too much time on this, but it's there. This is what I'm really emphasizing right here. Because if we assume that the electrical activity is moving down into the lower left area of the heart, then all of the other leads that I just described should start to make more sense. Okay?
I guess a quick question. So off of that image, so the lead 2 would be the most positive because it aligns with the direction the most in this situation.
Correct. I was going to get to that too, but lead 2 should be the most positive, and lead 2 should be the best lead to look for P waves because of that reason, right? It's basically, you could think of the SA node as being almost here. So the electrical impulse is traveling basically with lead 2 as it moves down to the AV node and the bundle of His and the bundle branches and the Purkinje fibers. So lead 2 is a good lead. And oftentimes when you look at a full EKG and they give you the rhythm strip, you actually see lead 2 as the rhythm strip, okay? I threw this in here. I'm not going to spend a lot of time, but it just matches up the different cardiac action potentials and the different phases on the EKG. I think we have a lot more other important stuff to go through, so I'm not going to talk about that too much. All right, so let's start into the P wave. So you guys probably know that the P wave represents atrial depolarization, okay? Very, very basic. The direction of the P wave is such that, number one, it's going to include both the right atrium and the left atrium, okay? That's why we get this little characteristic shape here. Of course, the right atrium is going to be stimulated first, and then the left atrium is going to be stimulated after that. If we think in terms of the positive electrode being down here, we start to see this positive deflection upwards, right? Because we're moving down as we're depolarizing essentially the right atrium, right? And then of course, eventually the left atrium as well. Everybody good with that?
Mm-hmm.
Okay. The important thing here is that as the signal is moving to the other atrium, that's when we start to see the deflection downwards, okay? Because we're basically, huh?
Is this lead 2? What lead is this that we're looking at?
Yeah, so that's a good question. So most of the time when they're showing these things, this is going to be lead 2.
Okay.
So unless shown otherwise, assume that it's lead 2. Yeah.
Okay.
So yeah, we're moving down this way, right? So if the signal is going now to the left ventricle, it's not quite directly on that vector line. So that's why we actually see the little deflection downwards. Okay?
Okay.
You guys can read all the text here. The next section here, I just wanted to see where they described it. This horizontal section that's between the end of the P wave and the start of the QRS complex, this is isoelectric, okay? Do you guys know why this is isoelectric? Why do we see a horizontal line?
Because the
AV node, yeah. Go ahead.
yeah, the electricity and the sodium and the salt are stuck in the AV node.
Right, so the signal is traveling to the AV node, okay? And there's going to be a delay seen when the signal travels from the SA node down into the AV node, okay? I think it's like 100 milliseconds, if I remember correctly.
Yeah.
Yeah.
That explains this section right here, okay?
Wait, but that little isoelectric line also includes the time that it takes for the conduction to pass through the ventricles as well, right?
Well, it's mainly through the AV node.
Okay.
Because remember the electrical conduction of the heart, once it goes to the AV node, then it goes to the bundle of His, and then from the bundle of His, it goes into the bundle branches, and the bundle branches wrap around, and then out here we have the Purkinje fibers, which are gonna depolarize the rest of the ventricle. So really, it's the time delay between the SA node to the AV node.
Miguel, I
All right.
think you're thinking about them filling with blood, not the conduction itself. I think the delay has to do with the ventricles filling up with blood, because the conduction will be the positive QRS.
Does the heart depolarize endocardium to pericardium or the other way around?
It's,
The ventricles.
I have it in here as well.
I think it's endo to epi.
Yeah,
Mhm.
same. I think yeah, into out.
Yeah.
Because the Purkinje fibers, they don't penetrate the myometrium.
Yeah,
Mm.
and then repolarization's backwards. Yeah.
Exactly. Okay, so are we okay with the P and the PR?
Yeah.
Yeah, I had a question though. So it is being delayed in the AV node, or the isoelectric thing is just going to the AV node?
So the isoelectric line represents the conduction delay from the SA node to the AV node.
Okay.
Does that make
Got it.
sense?
I got
Yeah.
another. I don't know if this might be too in depth, but is that because like the AV node, is there a difference in the conductance of like the ions in the AV node compared to the SA node, or isn't it just like the same kind of like channels and you know what I mean?
I think it's the
Is it like,
rate.
Yeah.
is it yeah, but what's causing that rate to change?
Todd,
Right.
so SA is calcium depolarization, and then the internodal tracks is like back to sodium. That's why it does it fast. But then an AV
No, I
node is again
understand.
calcium.
I understand, but why is it that like, okay, if we leave it up to the AV node, it drops the heart rate drops down to like 100 or whatever, or it drops, the amount drops, you know what I mean? The heart rate drops. Is that because of like different types of channels in there, or?
Yeah,
It
depolarization with
might be
calcium
so in
takes
depth.
longer.
No, not, I'm talking about between the SA and the AV. Why is the SA the pacemaker of the heart and not the AV node in that case, if they have the same type of channels?
Because it depolarizes faster per like.
But they have the same type of channels. Why don't they depolarize at the same rate? Why is it that it takes longer?
No, it's because
no, it has
I
the
don't think
funny
it's the funny
channels.
current.
Isn't the
They don't have
funny
the funny
current
channels.
The funny current is in both then. You guys don't get the question I'm asking. Justin, you get the question I'm
But it
asking?
has a slower funny current in the.
Okay, that would answer the question.
There's a slower funny current in the other ones.
In the AVs.
Except the fastest is in the SA. Yeah,
SA.
fastest in the
Okay.
SA, slower in the AV.
All right, thank you. That makes sense.
Okay. So moving on to the Q deflection. So, I mean, I'm going to read a little bit here, but the action potential is going to go from the AV node down into the bundle of His. All right. So basically, we're no longer going towards the positive electrode because it's going slightly on a diagonal downwards. So it's kind of similar to the P deflection downwards. Essentially, what's going on here is that we're moving away from that positive point on the heart. Okay, so that's why we get this little blip in the Q going downwards. Okay, because the bundle of His is somewhere over here, so it's going to go in the opposite direction. All right, that's basically the gist of it. We're also going to have to depolarize the septum going from left to right, and that's going to be included in there as well. The main idea here is that once we get into the bundle branches, then the depolarization signal is going to start to move towards this vector here. We're going to start to depolarize the ventricles. So you guys know as a whole, the QRS complex represents the depolarization of the ventricles, and it's going to be, again, in lead 2, it's going to be very, very positive because a couple of reasons. The vector's over here. You're going to hear me say that a lot. Also because the left ventricle is a lot thicker. There's a lot more muscle. So it's going to require a lot more signal to depolarize, and therefore we're going to see a very positive deflection.
Hey, Justin, is this possibly the lead 1? Because if I look at the heart here, the lead 2 would be like something close to the apex of the heart, right? It almost goes directly with the line.
It could be. Like, I don't really know. And honestly, it doesn't make that big of a difference here. That's why I think that they didn't take any time to highlight it. It could be 1, it could be 2. For all I know, it could be 3. It doesn't really make a difference here. This is but what it should be ideally. You know what I'm saying?
A slight deviation though, towards the left or the right, maybe let's say to the right of the heart, would still be, that vector would still have a positive direction with lead 2, but it would so like, you know, the vector's pointing, maybe it's down in this way, but you know, in vector 2, which is right here, they share vector, whereas like lead 1 might be in the negative direction. You know what I mean? So is it maybe that lead 2 doesn't typically have Q, or like a negative Q? It has like a flat Q?
It all depends. There's so much variation. No two hearts are going to be alike. You know, there's going to, if we were talking about practical purposes, that little difference doesn't make that much of a big deal, because we do get 12 leads and we do get to see the electrical activity all throughout the heart, right? So as a teaching point, yeah, sure, we could spend time on that, but I don't know if it's worth it.
Josh, really quick, what I learned was, so could you go back, Justin? So here, as it's going down the septum, so it's really the left bundle branch that does the septum. And so they actually have perpendicular fibers like that. And that's what's kind of depolarizing the septum. So because of that, so you can see the vector of that direction is in the opposite direction. That's why you have that Q wave that goes down. Pretty much that's why.
Thank you.
Yeah.
Thanks. Okay, let me just see if there's anything that I missed here. So now we can talk about the downward deflection going from R to S, but basically that has to do with the Purkinje fibers now moving the signal upwards. So that's why we see the negative deflection. Okay, everybody good there? This is pretty important. The normal QRS duration is 0.08 to 0.1. I'm going to go over how to determine that if you guys don't already know. But now we'll talk about the T wave. So the T wave, as you know, represents the ventricular repolarization. And as we mentioned, the depolarization goes from endo to epi, and the repolarization from epi to endo. Okay, so I'm not going to really spend a whole lot of time here. The words are there, but I think we have, other things to worry about. So you guys can read
Wait,
that.
quick question. So the arrows are representing repolarization, right?
Repolarization, yeah. That's why eventually at this point right here, the T wave is going to deflect downwards. Okay, that's what this is going to represent over time. The T wave is going to deflect downwards. Okay, this is not that important, right? We know that the normal T wave should look like this. Why it looks like this is probably not that important.
So where does the actual contraction happen on the curve? Where on the curve has the heart smallest?
Good old QRS.
During the QRS, it's contracting. I can't tell you at what point during this wave, a particular part of the heart is contracting. I just know that during the QRS complex, the ventricles are contracting because they're depolarizing, and the depolarization signal is making it contract. That's probably the extent of it. Right, you guys can. I really want to get into this stuff, okay? Because this is the really important stuff. We know the shapes of the waves and what they should be. The PR interval should be between 0.12 and 0.2 seconds. So each one of these little boxes is 0.04 seconds. So the easiest way to do this is just literally to count, okay? So when we talk about a PR interval, we're always starting at the beginning of the wave. So here would be the start of the P wave. And then the R is going to be, I don't really like this drawing all that much, but we can tell that it fits within 1, 2, 3, about 4 boxes, okay? So it's going to be 0.16 in this case, or more or less. The actual numbers, if it's 0.14, 0.16, 0.18, it doesn't matter, as long as it fits within this range. Because if we have prolonged PR intervals, that's when we start to see heart blocks, okay? We have the QT interval. This is actually very, very important because if we have a prolonged QT interval, we can have some serious results, could lead to cardiac death. So normally it's around 400 milliseconds. And I'm going to talk about long QT interval and short QT intervals a little bit later. But the text is there just for you guys to review. The ST segment, the time, yes, it's important, but mainly the ST segment is going to be important for ischemia and infarction. So anytime you see consistent ST elevations in certain leads, then it's very suggestive of an MI. If we see depression in certain leads, it's going to be suggestive of ischemia, which may not necessarily lead to infarction. Do you guys know the difference between ischemia and infarction?
Yeah.
Okay.
Ischemia is the necrosis caused by infarction is the necrosis caused by ischemia.
Right. So ischemia just refers to a decrease in blood to a particular area, in this case, probably the myocardium. Infarction is actual tissue death as a result of sustained lack of oxygen. Now we'll talk about the precordial leads. So the precordial leads are going to all be positive. They share a common central terminal, fine. The most important part here is that they basically represent the activity on the heart, okay? The other stuff is the chest wall. This is going to be directly on the heart. The major take-home point here is that we're going to be looking at the R wave progression, all right? So going from V1 all the way to V6, we should see this progression in R waves. V1 should be very negative. V2 should be less. V3 should be even less. We'll even see some more positive. V4 should start to get very positive. V5 even more, and V6, if if perfect, should be all positive. And the way that I like to think about this goes back to going left. If we look at the precordial leads, V1 is on the right side of the sternum. V2, now we've crossed over. V3, V4, V5, V6 get even more lateral, more to the left. Okay, so it's with respect to that signal going down to the left. Everybody good?
Yep.
Yes, sir.
This right here, I mean, all these slides are important, but this is one of the most important slides because this has to do with the leads of the precordial V1, V2 through V6, whether we're looking at the inferior, lateral, anterior, or septal, and also which coronary artery is supplied or is represented by each of these leads. So this is something I would absolutely positively memorize, okay? So the inferior leads are gonna be 2, 3, and AVF. I think, was it Koss who said something? AVF, you're looking like from the floor, so you're looking from downwards. So that could be a good way to remember that. One,
Also,
and, huh?
Yeah, also, if you remember that F means, just take this meaning as foot, I never forget it that way.
Yeah, that's good.
I have a quick question. So I'm trying to find like a picture of the leads. Where is like the actual AVF lead placed on the body?
That's a good question.
It's a combination between, it's like a combination, right? Yeah.
Because I can find an image for V1 through V6.
Michael, I think actually, so those are augmented. So there's no, it actually uses the right lower limb. Like it uses the left limb one. Does that make sense? Like it's an augmented thing. The ECG machine is making those nodes on their own. So there's no extra lead. So you remember the triangle, how you have the positive node on that right lower, the left lower one, and the upper two are negative. So that's how that works. So it's not an extra lead. The ECG machine uses those leads to augment and create an artificial node system. That's
okay. So outside of V1 through V6, all the other ones are virtual using the LL, RA, LA, and RL leads, right?
Yes.
Yeah.
Okay. Thank you.
All right, cool. Yeah, so you guys, like I said, have to memorize this chart. This is very important here. I'm not going to go through each one, but we're going to see this a little bit later too when I start talking about ischemia and infarct. So this is a slide that's very important. I know a lot of people were asking, like, how do we approach these EKGs rather than just like kind of looking all over the place? So there is a methodical approach. You should first look at the rate. And I think you guys probably know how to find the rate. If not, we're going to go through it. The rhythm. So a couple of things we want to look for. Is it regular or irregular? Do we have a PQRST? Is there a QRS for every P? If we have more P's than QRSs, it implies that the heart is dropping some of the QRS complexes, which is significant for heart block. We'll talk about the different types. The PR interval I've mentioned before. If we have a PR interval that's greater than 0.2 seconds, that implies first degree heart block. But again, we'll talk about that more. The QRS complexes, is it narrow or wide? This is important because it could represent conduction delays through the ventricles, namely right bundle branch blocks, left bundle branch blocks, etc. The QT or QTC interval should be, I've seen 0.4 to 0.45, I think for males, and 0.4 to 0.47 for females. Maybe I have that reversed, but that should be very consistent. I think I should have a slide. Yeah, I talk a little bit more about the QT interval and the corrected QT interval in another slide, so we'll get there also. The axis, here it says the actual degrees, but I don't think they ever taught us that. So the quick and dirty way of finding the mean electrical axis is by looking at the two leads, 1 and AVF. Hypertrophy, typically if we say have a right axis deviation, we tend to have, wait, let me say that again. If we have a right ventricular hypertrophy, we tend to have a right axis deviation. If we have a left ventricular hypertrophy, we tend to have a left axis deviation. We'll talk about that. The amplitude of the RNS, we want to make sure that things are consistent. And then I've talked a little bit about ischemia and infarct, and then we'll get to that as well. The T wave can also be clues as to, if there's anything going on. In hyperkalemia, for example, we will see very, very peaked T waves. In hypokalemia, we'll see that T wave kind of flattening out. Just different examples. We'll go more into detail about all that. It's important that we understand these boxes here. So I've said before, each little box represents 0.04 seconds. It also represents 1 millimeter. There's 5 little boxes in one big box. So if we do multiplication, each big box represents 0.2 seconds, okay? If we go this way, I know they're squares, but if we look at it this way vertically, the entire big box would be 5 millimeters. This becomes important if we're looking for hypertrophy. So the Sokolow-Lyon criteria, that has to do with diagnosing left ventricular hypertrophy or right ventricular hypertrophy. Basically, you would see QRS complexes that are really, really big, up or down, and we'll see that. Any questions so far? Now we're gonna get into actually figuring out the heart rate. So there's at least 3 ways of doing this. We could, basically what we do is we take a QRS complex that falls on a thick line, and we can count down from 300 using these very specific numbers. The way that I like to do it is I like to actually count thick lines until I get another QRS complex that's either on another line or very damn close to another line. And I take 300 and I divide by the number of solid lines it takes to get to the next QRS complex. So in this case, if I'm starting here, I'm going to count 1, 2, 3, 4, or about 4, okay? So the heart rate is 300 divided by about 4. So that would give me about 75, okay? The key here is that there really is no difference between 75, 73, 82, 84, 79. It's normal heart rate, okay? So I like to use the 300 divided by the number of boxes. If you guys really want, you can memorize these numbers. That's up to you, okay? We can then calculate intervals. So this is basically just counting up little boxes again and multiplying by however many boxes there are. I don't remember if they said we need to memorize these values, but it certainly doesn't hurt. Again, the PR interval should be between 0.12 and 0.2. So, you know, we can count to make sure that the PR interval in this case falls within that range, and it does. The QRS complex should be less than 0.10 seconds. You know, here it's 1.5 little boxes, so that gives us 0.06. And then the QT interval should be somewhere around 0.4, maybe a lot less, or not a lot less, but it could be less when we calculate the corrected QT. We'll see that, okay?
Just a quick question, Justin. Yeah. Is the QT from the Q to the end of the T or to the beginning of the T?
The Q is, that's a good question. The Q is from here to the end of the T.
Okay.
Okay, so the start of the Q to the end of the T. Yep. That's important because if you don't take it at the right spot, you could miscalculate it. So here I tried to show the normal EKG with respect to the position of the leads and what types of things that we should see here. So just looking right away, this is normal, of course. We see lead 1 is positive. We see lead 2 is also positive. Lead 3 is a bit, not 100% positive, not 100% negative. That's okay. There's going to be some natural variation. Importantly, we see AVR is negative, positive, right? Because we're going in this direction. AVF is positive because we're going in that direction, right? Or that direction towards the floor. And then we look at our precordials. We see that we have a good progression of R waves. We see that the R wave overall starts to flip, and then by V6, we have a positive deflecting R, or QRS. These 3 down here, I don't know why they pick 3 rhythm strips. Sometimes they'll give you 1, sometimes they'll give you 2. These are just expanded versions of particular leads. And here we have lead 2, so that's very nice. kind of previewing ahead, but we could see P waves very nicely. We could see that each P triggers a QRS, and then we have that little bump right there. That is going to be a T wave, and everything looks pretty regular. Okay. So any questions so far? Because now we're going to start to get into some of the irregularities.
Yeah, I had a question.
Yep.
So you said, didn't you say like the V1 to V6 are always going to be positive, or was that?
It should be, yeah.
So like the V1 in this guy is like, is that abnormal?
So it should be, no, V1 should be negative, right? V1 should be negative, and then as we transition down into V6, we should.
Oh, it gets more positive.
It gets more positive, right?
Okay.
There's going to be natural variation when you look at real EKGs, because as I said, everybody's heart is going to be slightly different, but that doesn't necessarily mean there's pathology. Also, an important point is you're not just going to get an EKG in real life and, you know, say, hey, what the hell's wrong with this person? They're going to give you symptoms, right? The person's going to come in with symptoms. And if you take an EKG on somebody who's perfectly normal, if they have a little variation in the EKG, it doesn't necessarily mean that there's something wrong with them. Okay, so that's an important point as well. For us, you know, we're given EKGs. We may or may not be given all the symptoms, but yeah, that's my spiel. All right. Everyone good?
Yep.
So now we can start talking about some of the irregularities. I tried to do my best in including a bunch of them from, you know, her slides and some of the more common ones. So we're going to go through some of these together. So using that systematic approach, the first thing that we should do is calculate the rate. So what's the rate of this first one here?
About 50.
How do you get 50?
Maybe about 85.
Okay.
Well,
better.
3.5.
Yeah. So if I'm starting here, right, give or take. So one.
Oh, I did the bottom one. My bad. I did the bottom one.
Oh yeah, we're doing the top one.
Yeah.
We're doing the normal first. So this right here, right? So we count 1, 2, 3, about 4. Okay. So about 75. Here they tell you it's 83. Someone said 85. That's really good. But there really is no difference between 75, 83, and 85. Okay. The rate is normal. Now, I know it says normal sinus rhythm right here, 1-to-1 ratio, blah, blah. I probably should have blocked that out. But do we have P waves?
Mm-hmm.
Yes, sir.
We do, right? Do we have QRSs?
Mm-hmm.
Absolutely. Do we have T waves?
Yeah.
Mm-hmm.
Do we have a P following, a P before every QRS before a T?
Okay.
Yeah.
Because we do, it tells me that the heart is being paced by the SA node. Okay. If the heart is being paced by the SA node, we call that normal sinus rhythm. We have a 1-to-1 ratio between P, QRS, and T. Okay. And it fits within 60 to 99 beats per minute. Everybody good?
Yeah.
This next one here, first of all, let's figure out the rate. What's the rate?
That's the 61.
Yeah. So depends on which box, but 1, 2, 3, 4, 5, 6, right? So 300 divided by 6 is
50.
About 50. Okay. Now, this one's a little bit tricky. Do we have P waves?
Yeah.
Yes.
Yeah.
But they're inverted.
Inverted, yeah.
They're upside down. Hold that thought. Do we have QRS complexes?
Yeah.
Mm-hmm.
Do we have T waves?
Mm-hmm.
Okay. So some people might say that because we have P waves, that this is normal sinus rhythm. But you guys just pointed out that the P waves are upside down. So what does that actually mean?
Is this lead 2?
Again,
Or like the reason why I'm asking is because I'm trying to think of the way the electricity, the depolarization is moving.
to make life easy, to make life easy, you could think of this as being lead 2.
It's being paced by it's causing retrograde depolarization of the atria. That's why it's inverted.
Exactly. So this is kind of fancy, but what's actually going on is that the heart is being paced by the AV node. One thing
that makes sense.
One thing that tells me that is the actual heart rate itself. Okay. we probably know that the AV node, what is the rate? It's like 40 to 60 or something.
Yeah, I think
AV,
it's 40
yeah.
to 60.
There, okay, 40 to 60. So that fits within that. And then also, what's going on here? I like that you guys are putting things together. If this is lead 2, the negative deflection of the P wave tells us that it's going backwards. So you're absolutely correct.
So P waves and the QRS complex should always be in the same direction, no matter where the lead is. Is that right?
That's a good question.
Because they're both depolarizing the same way, right? So they should always match up whether they're flipped or not.
Yeah, I mean, I never thought about that, but that should be the case.
For normal sinus rhythm, yeah, it should always be okay.
Normal sinus, it should be the case.
Okay, so I guess it's helpful if they're ever. I feel like we should probably check on this first, but like if they're ever not matched up, then
yeah.
In V1, it'd be separate because the node is in between the atrium and the ventricles. So a correct polarization in V1, the atrium, the P wave would be positive because it's moving towards that, and then the ventricular one would be negative because it's moving away.
Here, the P wave looks.
P waves are negative, yeah.
These are negative P waves.
Maybe I'm wrong. I was, well, I'm probably wrong then, but that seemed to be the case.
Yeah, I think it might be suffice to say that they should be in the same direction at all times. Don't hold me to that, but that sounds.
Justin, that's called. Sorry, that's called junctional rhythm, junctional atrial rhythm, or.
Yeah, so I'm gonna explain that now. So basically, the rhythm is coming from somewhere between the SA node and I guess you could say the ventricle, right? It's somewhere, in this case, it's being paced by the AV node. You know that based on the heart rate itself. If this heart rate was a little bit different, then you can make a case to say that it's being paced by the actual ventricle or by somewhere in between that pathway. It could be being paced by the atrium, right? The point is that because the P waves are upside down, it's not being paced by the SA node. So this is not sinus rhythm. This is a junctional rhythm. Junctional just means somewhere in between that normal conduction pathway, right? In the junction between the normal pathway.
Right.
Everybody good? Any questions? Okay. All right, so we have some pretty characteristic shapes for very particular rhythms. That's why I put these in here. I want you guys to start to be able to identify some of them, but forget all that. Let's calculate the heart rate first. What's the heart rate here?
Between like 100 and 150. Like
Okay.
120.
Okay, so it's high, right? What do we call that? We call a high heart rate. Tachycardia. Do we see P waves?
Yeah.
Yes, sir.
Okay. We see a QRS following every P wave.
Every single one.
Every single one. Do we see normal T waves?
Yeah.
So what do we call this?
Atrial
Ventricular tachycardia.
What is it?
Or atrial, sorry, yeah. Atrial tachycardia.
Okay, so I would call it sinus tachycardia. The reason why I call this sinus tachycardia is because it's being paced by the sinoatrial node. The term atrial tachycardia implies that the heart is being paced by the atrium, not the SA node. Okay, that's a big difference. Remember that, you know I skimmed through it real fast, but we have different action potentials depending on if we're talking about the muscle itself or the SA node or the AV node. Okay, so as long as we have P waves, we're talking about a sinus rhythm, normal P waves. Okay. So yeah, it's about 125. What about this bottom one here?
It's a 50 heart rate.
Yep.
Yeah.
Sinus bradycardia?
It would be sinus bradycardia. Good. Because we have P waves, and then we have QRSs, and then we have normal T. Well, we have normal QRSs, then we have normal Ts. And we have a P, a normal QRS, and then a T, and so on and so forth. So just by looking at this with the naked eye, you can tell that this is a very fast heart rate. Right? We see repeating cycles very, very quickly compared to a sinus bradycardia. This doesn't necessarily have to be pathological. So you guys have probably seen, you know, professional athletes, they have really low heart rates.
Yeah.
But it's not necessarily pathological.
I heard Kobe Bryant's was like 32.
Exactly.
Wow.
So what happens, the stroke volume actually increases, right, in compensation. So his
way more efficient heart.
Exactly. All right. So we good with those basics, because from now on it's going to get harder. So now we start to get into the heart blocks. So the first degree heart block looks like this, okay? I still want to approach it like we did. Oh, shoot. I forgot to do the meter. Oh, no, we can't anyways. Never mind. Sorry. So we have the rate first, okay? What's the rate here?
About 60.
60.
1, 2, 3, 4, 5. 60 is good, okay? We see P, QRS, T, P, QRS, T, blah, 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 okay? Now, the definition of first degree heart block or incomplete heart block is this. First of all, we have to have a sinus rhythm. We have to have PQRST for every beat that we do. We also need to have the PR intervals exceeding 0.2 seconds. So if I was to calculate the PR interval for any particular beat, if I start right here, I'm going from here to here, okay? And you know, you can count every little box if you want, or you can eyeball it. So we know that 0.2 is how many little squares?
5.
5, right? Or one big box. So to me, it certainly looks like this PR interval goes beyond
one big
box. Okay. It's kind of hard to tell, but it.
Well, it looks like twice the size.
Right. Exactly. Well, yeah, that's true. Sorry. Never mind. You're right. I wanted to say something else. Oh yeah, this is not necessarily pathological either. Okay. I put some of the causes here just in case it comes up, but that's for reference. Okay. Any questions with first degree heart block? It's sinus rhythm. It's going to be slower, but we have an extension of the PR interval. Now we can get into the second degree heart blocks, okay? And these are even a little bit more complicated. So this picture here shows we have a Mobitz type 1 and we have a Mobitz type 2. Mobitz type 1 is also called Winky-Bach. So if you see that, just recognize it. Basically, with a Mobitz type 1, we have the signal not going from the SA node down into the AV node. So we have this conduction blocked. Whereas in a type 2 Mobitz, the conduction signal can get to the AV node, but it's not moving downwards into the bundle of His and then subsequently in the left and right bundle branches. Okay, so keep that in mind. When we look at a Mobitz type 1, first of all, I assume you guys all can do the rate now. We can also do the rhythm, right? Very basic rhythms. So first of all, is this sinus?
Yeah.
Yes.
The rate, yeah.
Okay.
Yeah.
EQRS and TR all there, yeah.
Right. Okay. So when I look here, I mean, it tells us right here, we want to make sure that the PR intervals are normal, okay, are consistent. Here, they're lengthening. That's one characteristic of Mobitz type 1. Another huge characteristic of Mobitz type 1, and actually the other Mobitz as well, is that we're dropping a QRS complex. Okay, so lengthening PR intervals and dropped QRS complexes. On a slide like this, it's very easy to see lengthening PR intervals, drop QRS. On a real EKG, sometimes it's a little bit more difficult to tell the lengthening of the PR intervals. But if you start here and you sort of count the boxes, and then you go here and count the boxes and so on and so forth, if it is a type 1, you will be able to see it. All right. If we compare that to Mobitz type 2, we still have a dropped QRS complex. But the huge difference between Mobitz type 1 and Mobitz type 2 is that in Mobitz type 2, the PR interval is consistent all throughout. So we do not have any lengthening of the PR interval, but we still have a drop of the QRS complex.
Just to like conceptualize it, why would that happen? I know this might be a little too in depth again, but I'm trying to like connect the dots to why it would lengthen throughout time and then drop the QRS.
Could I try taking a crack at that? And then Justin, can you tell me if I'm right?
Okay.
Okay. So my guess is the SA node is it's got its own beat, right? And then so it's got to send the signal to the AV node. So in Mobitz type 1, I imagine what's happening is the SA node sends a continuous, like a very regular cycle, but the AV node is going much slower, and then so like it might not polarize. Maybe the first go it polarizes normally, but then it's still repolarizing while the SA node sends its second one and it's not ready, and then so it takes a little longer to.
Oh, I see.
Sorry,
go ahead.
In the Mobitz type 2, the reason why doesn't show up is because the AV node is still going to send the signal, which is going to end the PR, the PR segment. So that whole segment is going to be normally paced, and the problem is that the signal will literally just eventually not be able to keep up through the bundle of His, and then so it's going to drop the QRS because eventually the bundle of His is going to slow down and not have enough polarity to like send the signal, but that doesn't mean that the PR is going to be changed.
So to summarize that, you can basically think of this picture right here. So in Mobitz type 1, the deficit is from the SA node to the AV node. So it basically is taking longer for the signal to go from the SA node to the AV node. And as I described earlier, that's corresponded by the PR.
Yeah.
Right, the PR interval. So this literally means and literally shows a time delay in the signal moving from the SA node to the AV node.
Yeah, no, I get that. I was just wondering why it was lengthening, and Josh's explanation kind of made sense because if it's not depolarizing at the right time, and that's a second. I have a follow-up question actually. Is there a refractory period for the nodes?
Is there a refractory period for the nodes?
Yeah,
I feel like refractory, right? Because if there was no refractory period, then something could happen where the nodes fire like crazy, and it could eventually
stay depolarized the whole time
to tetany, right? Because we are talking about muscle, so you can't tetanize the heart because of the refractory periods.
Yeah, I remember.
Probably masked by the QRS.
There. I don't know if it's like an absolute refractory period, but like when they're left on their own, they all have their individual refractory periods, and they like fire at a different rate. So it's like the SA node, like has like a certain like beats per minute, like, and that's just like how it fires, and that's like it just does that. And if it's like kind of blocked, then AV node has its own that it can do, like generate, and then the bundle has their own. So if the AV node is not sending a signal, then they'll do their own thing.
Mm-hmm.
Cool.
Yep, that sounds good.
Justin, I have a question. So if we're given like an EKG or whatever, so the characteristic for a second degree heart block would be just a drop QRS, right? And then there would be the two types. If we see the PR interval lengthening, then it's the Mobitz type 1, right? That's just like the only thing that we need to know, basically.
Yeah, to summarize.
Okay, cool.
I don't think we're going to be tested on the mechanism of it. We just have to be able to identify if it's a Mobitz type 1 or Mobitz type 2.
Cool, thanks.
So what helped me was just saying it out loud a bunch of times. I did something stupid. I take my little fingers and I go broop, 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 and then broop. And
it's cute.
It works that it's Mobitz type 1. But if it's a Mobitz type 2, it goes broop, 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 and then broop. So I don't know if that helps, but I come up with a bunch of stupid stuff, as you know.
You have to make the noise too.
Absolutely, every time. All right. So that's the second degree. The third degree, in my opinion, is the hardest to recognize, especially at the beginning. So I'm going to try to do my best here. Basically, in third degree heart block, no impulses at all are being traveled through the AV node, okay? So one way you could think about this is that the P waves are doing their own thing and the QRS complexes are also doing their own thing, all right? So this is going to take a lot of practice to be able to recognize, but one thing that we can do, if we were to map out these P waves, and by that I mean, you could take your fingers if you want, you can basically place them on the P waves and you can move your fingers all the way through the EKG, they should match up. Same thing with the QRSs. The QRSs should match up as you're moving down the EKG, unless of course you have a dropped QRS somewhere that, messes up that pattern. But for the most part, it should match up, okay? So that's sort of the best way that I can describe this. We know that it doesn't look like Mobitz type 1, right? It doesn't look like Mobitz type 2. I know I'm kind of explaining this kind of crappy, but this one's kind of tough. If anyone has any tidbits, please.
It's exactly what you said. I think that's what Dr. Saxner was saying. It's like the ATR kind of firing on its own and the ventricles are firing on its own, but they're firing at a consistent rate. So yeah, every distance between the P wave is going to be the same, and every distance between the R and R is going to be the same.
Exactly. That's important.
I think she also said something about how like you can see more P waves in QRS, which also kind of makes sense because you're gonna have like more firing of the. So
I think that meant something else too. Like if you depends on the third degree heart block, if you had more ventricular ventricular rate is higher, then you have something called AV dissociation. Whereas if you have the atrial rate higher than the ventricular, so if you have more P waves, you have third degree heart block. If you have more QRSs, you have AV dissociation. It's just like a like naming thing about it.
Yeah, that sounds good. So I have the text here. I'm not going to read through it because it's basically what I just said. But Todd, as you just pointed out, this bottom line here is important. 2 to 4 P waves for every QRS complex. So that just furthers your point right there. All right. So I wish I could, explain that a little bit better, but it's just going to take some practice in recognizing them. All right. Now, these are 2 very specific rhythms. I kind of gave some clues here for this first one. So we have no clear P waves. We have a lack of coordination between the atria and the ventricles. The rhythm is erratic and tachycardic. So when we try to calculate the heart rate using that counting and divide into 300 method, we're kind of assuming that those RR intervals are consistent, right? They're regularly regular. But in this case, they're not. They're irregularly irregular. So what rhythm do we have here?
Atrial fibrillation.
AFib.
AFib. Okay.
Is there only 2 things where it's like regular, irregular, and then irregular, irregular, or is it like, can there be like the?
Yeah, I have a slide here.
Okay, cool.
Regular,
I don't know if that was a dumb question, but I don't think I know this.
And irregular. Okay.
All right, cool. We can go to that.
I'm gonna tie it together with the heart blocks.
Cool. Thanks.
So yeah, this is VFib. When you don't see clear P waves, when you see like this erratic activity here before the QRSs, we're talking about AFib. Okay, this is just pattern recognition. What is this rhythm right here?
VFib.
VTAC or
VFib, the better answer, right? Notice that there's no pattern here. All right, so these QRS complexes don't really look consistent all throughout. Right here, they're really tiny, then they get sort of bigger again. It's just the ventricles are going like this, basically. Okay.
Well, doesn't that kind of look like torsades though, because it kind of gets like narrower and bigger?
Yeah. So that's a good question. Torsades, you kind of have like that loop on the EKG. You know what I'm saying? Like.
Yeah. Yeah. Torsades just means twisting of points, so you have to see like it does like the loop thing, and it twists before it does it again.
Yeah, it actually like turns a little bit, if you will.
Yeah.
It's kind of like that. But
I think it's because like the amplitudes in this are pretty consistent. I think in torsades they change around a lot. So that's kind of why it looks like it's looping.
Okay.
Okay. So AFib and VFib. Now a little bit about the long QT syndrome. So we calculate the QT interval. We can do this by counting the boxes. That's pretty straightforward. But what we need to do, so the normal QT interval is calculated on the printout, but they also give us the QTC interval. The way that that works is that we have to take the RR interval, we take the square root of that, and then we do the normal QT interval divided by the square root of the RR interval. In real life, this is calculated for us. We might have to do this, I don't know. So I would definitely remember this formula here.
And what does it mean?
It's basically, it shows the overall activity of the ventricles. So it's the start of the ventricular depolarization and into the end of ventricular repolarization.
I forgot where it was explained, but it says that whenever your heart starts beating faster, the QT actually shortens.
Yep.
So to correct for that, you do this equation. So like it might look like you're having a short QT interval because your heart's beating so fast, but in reality, your QT might be normal or actually, I don't know, maybe extended.
Right, depending on what your heart rate is. Exactly. Yeah. So that, yeah, like I said, the normal QT interval was based on a heart rate of 60, but there's fluctuations. So that's why we correct it. Okay. So I think I said earlier, the normal QTC interval for a man is around 450 milliseconds. For a woman, it's about 470. And any lengthening of the QT could be very bad. I think it could lead to cardiac death. And I know you guys have seen Anki cards that say this drug prolongs the QT interval, right? So this is where that all ties in. You're basically lengthening the time it takes for the ventricles to depolarize and then repolarize. Remember, this needs to happen pretty quickly, right? So if that process is taking longer, then there's a chance that the ventricles might not contract in the appropriate amount of time, which could have, long-lasting effects.
Just to conceptualize it, Justin, is this like the ventricles stay contracted for like that period of time?
You could think of it like that, I suppose, right? Because, the Q is probably not changing, but the T is going to be further out here. So yeah, it's taking longer to reset. So therefore, the ventricles are going to stay polarized and not reset. Cool. That works for me. All right. So here's the rhythm, the regularly regular, the regularly irregular, and the irregularly irregular. So regularly regular means that the RR interval is the same all throughout. So this is what we would see in first degree heart block, okay? Yes, the PR interval is lengthened. Yes, it's taking longer for the signal to go from the SA node into the AV node. But if we look at these RR intervals, they're pretty consistent. So it's regularly regular. In regularly irregular, this is going to be our second degree heart blocks. So of course, by dropping a QRS complex, we're changing the RR interval at a particular place in the EKG. Okay. So I think you guys can all see that. And then irregularly irregular just means everything is out of control. There's no regularity whatsoever. And that's where we would see AFib.
Cool.
Okay. All right. So let's do this.
Okay.
Can we answer? Or is it like a choice?
You can shout it out.
Oh.
Yeah, it's B.
Normal?
Oh, wait, no, yeah. No, it's sinus bradycardia.
Sinus brady, right?
Oh, yeah, okay. Yeah, that's true.
Yeah, so it's not quite first degree heart block, right? Because this PR interval looks pretty normal. We have like 2 boxes here and like 3 here. So it's pretty normal. It is sinus because we have P, QRST, P, QRST, P, QRST. So as you guys are looking at a lot of EKGs, you could just tell eventually that this is a very slow heart rate, right? I didn't actually calculate the rate, but you can just tell. All right.
Okay.
So I'm just thinking of something. I may have misspoke. I may have called the segment the interval. I think I did that. So the PR interval is from the beginning of the P wave to here. The actual activity or the actual transition from the SA node to the AV node is the PR segment. Segments are isoelectric lines. So if I mix those up, I'm sorry, I'm correcting myself now. It's the PR segment.
Wait, what was that from where to where again?
The segment is from here to here.
No,
so
you said
so C the answer?
Huh?
Is it C?
It's
B.
It's B, right?
Yeah.
It's
Yeah.
0.04 second per square.
Right. Let me see. Do I have a? I don't know. But basically, it's from right here. I know it's kind of hard to see, but where the top arrow is, that's where we start, and then we're counting over 1 box, 2 box to that point right there. Okay.
Isn't that the Q though, or like R? Like, do we start the R there, or do we start at the top of?
It's the isoelectric line. So I think
Okay.
they, in another place, they call it the PR. Some places they call it the PQ, but it, for all intents and purposes, just think of it as the isoelectric line. So now that I'm thinking about it, I think I did call this the PR interval. This is the PR segment. Just like this is the ST segment. Segments are always isoelectric lines.
So
I think they call it. I think sometimes you don't see a Q wave, so it's either to PQ or to PR. So it's like beginning of the QRS complex is where you measure to, which is why
Okay, that makes sense.
Yeah, that's good. That's good. Thanks.
So for first degree heart block, it's still the PR interval, right? Not the PR segment.
Yes, exactly. It would be from the start of the P to
the start of the QRS.
Right, exactly. So I'm glad that came up so I can correct myself. All right, so you guys want to do this? We didn't really talk too much about the mean electrical axis. I guess this is a place where we could do that.
Talk about what?
The mean electrical axis. There's a question here, that asks for it.
Let me see.
But I mean, you don't have to. This was just there, for practice. But I thought I put that in somewhere else. Shit, I might have forgot to put that in. Yep, I think I did. My bad. All right, so how do we calculate the mean electrical axis?
Looking at the strip, looking at what's deflecting, where it's pointing to.
Yeah. Let me just go ahead and do this. I'm going to, real quick, add something else in. Can't believe I forgot to put that in. Give me 1 sec. Okay, so this method right here is the method that they showed us in class. So we're going to look at lead 1 and lead AVF. So we're starting with lead 1. If lead 1 is positive, we then move on to lead AVF. If lead AVF is also positive, then we have a normal axis. Okay, this is something you just have to memorize. If lead 1 is positive and lead AVF is negative, then we have a left axis deviation. So lead 1 positive, AVF negative, left axis deviation. If we have a negative lead 1 right away, we're probably going to have a right axis deviation, but definitely if AVF is positive. Okay, so just memorize this chart. That's all I can tell you.
What is axis deviation? If you just like a short blurb.
So it basically means that the totality of the vector of depolarization is shifted in either the left axis or the right axis of the heart. So the best way that I can put this is take somebody who has a really big left ventricle. That left ventricle is going to require a lot of electrical activity to stimulate. So you may see a left axis deviation. It may turn that vector more towards the like higher up. If you have a right axis deviation, it could be because of a right ventricular hypertrophy. So, for the same reasons, the right ventricle would require a lot more electrical activity to function, and therefore it would pull the depolarization more towards the right. But that's
Isn't the left ventricle almost always bigger than the right ventricle?
Yeah, but we're talking like extreme hypertrophy.
Oh, okay.
Yeah.
Got it.
So yeah, that's what I was gonna ask too. So it'd be okay to associate left deviation with left hypertrophy and right deviation with right hypertrophy?
I think it's better to associate the hypertrophies with the deviations, because just because you have a deviation doesn't necessarily mean you're going to have a hypertrophy, because there could be other causes of the deviation.
Okay, cool. Yeah.
Does anyone know? So in boards, I'm pretty sure when they taught the EKGs for the axes, they use lead 1 and lead 2 as the directions to like look at to confirm. Is it like the same? Just like, does it work the same principle for the AVF instead of lead 2?
Yeah, I think there was something where like if lead 1's positive and AVF is negative, you're supposed to make sure that lead 2 is also negative for some reason.
Yeah.
Yeah.
Yeah. If you think about it, they both point the same way. AVF and lead 2 point the same way, so they should show the same.
Yeah, like down.
Right. Exactly.
But yeah, I think there's for some reason that you can't just assume with AVF being negative. You have to check lead 2, but I don't know why. If anyone knows why, that would be helpful. Otherwise,
it's because technically you can have a normal axis between 0 and 30 degrees. So
I'm gonna get into that, but yeah. Yep.
Oh, okay.
Cool.
Yeah. If you really want, I can, but they didn't mention it at all, so I just decided to skip it.
No, that's all right. I just was wondering if there's a difference.
Guy said. All right. So again, I'm just trying to make this as easy as possible. Okay. There's at least 3 or 4 ways that we can figure out the mean electrical axis. I learned a way that had to do with drawing vectors, that thing with the angles and stuff like that, but this is so much better.
Yeah.
You can also use the chest leads.
Yeah. Yeah. There's many ways, but we're gonna stick with this. All right. You guys want to have some practice?
Yeah.
So just shout it out.
A, sinus bradycardia.
Sinus rhythm is G.
Let's go down column A and match it up with column B. So which one of these is normal sinus?
G.
Oh, wait, normal sinus.
Yeah.
G.
G, right. So I'm assuming that you guys, other than like the pattern recognition for something like this or even like this,
yeah,
you're calculating the heart rate, you're looking PQRST, PQRST. You should really get in the habit of doing that.
Mm-hmm. Is B a 3rd degree heart block?
Yes. Good.
Type 2.
Huh?
Which one are we doing?
Ventricular fibrillation is D.
D.
D. Yeah.
AFib is I.
I.
Yeah. What has a prolonged PR?
Sinus tachy.
F.
Oh, C.
C.
Yeah.
C.
That first degree heart block.
Yeah,
is
C. 100%.
100%.
You're saying that
100%.
is first.
First degree heart block, yeah.
What's the easiest way to determine 1st degree heart block versus the 2nd and 3rd degree heart blocks?
There's no drop QRS.
Exactly.
No, the segment. The PR, the PR, not the segment. Yeah, the segment.
Interval.
Or interval. Sorry, not the segment.
That's true, but the first thing you should do is you should see if there's any drop QRS complexes. Because if there's any drop QRSs, then it's 2nd degree or 3rd degree heart block.
How often do those QRS complexes come? Because I think she was saying like you might not see it for like
10,
20
they might.
beats.
Yeah, it depends.
She's saying that.
Depends on the rhythm.
Okay.
Yeah, you see things like 4-3, 4, like for 2nd and 3rd degree heart block, you might see like 4-3, 5-2, right? That's just the ratio between P's and Q's.
I think F has a dropped QRS.
It does.
F and H. F and H.
F and H, yeah.
F Mobit's 1.
And then
Mobit looks like it's extending.
For F?
Wait,
Mobit 1.
If it's, Mobit's 1, yeah.
Yeah, you're correct. Because this, as you said, you're dropping a QRS, and then it's kind of hard to tell, but you're you're lengthening the PR interval.
Really? Well, the other one, you're not lengthening the QR or the PR interval?
No, in H.
Yeah, you are.
You can eyeball.
No, not for this one. The other one, what is it?
Type 2, you don't lengthen it, no.
Right.
I meant to say in the picture, H is not. I can't tell. It's too small. H is the type.
The way that she said it in lecture was really helpful because You just look for the dropped one, and then you look at the PR segment before and after the drop. Since the one right before the drop should be the longest, it'll be very obvious the difference in those segments. That's what she was talking about in lecture, and I think that was a helpful way.
That's really good. Okay. Let's see. So we got Mobitz 2, third degree we said was B, right?
B. Mm-hmm.
And then sinus tachy and sinus Brady, those are
sinus tachy would be E and G.
Good. So the reason why I threw this in here is because before we can start diagnosing all this crazy stuff, we have to know what normal looks like. Okay. Now we can start to talk about some of the pathology, if there's no questions. So I just kind of threw in as much as I could here, the more high yield type stuff. So we'll start talking about the right bundle branch blocks. So with the right bundle branch block, the first place that I always look is V1. Now, again, I'm no expert on this, but if I see bunny ears in V1, I'm thinking right bundle branch block. So this is just a characteristic pattern here. I don't know to what extent we need to know why this is happening, but basically the signal is being blocked in the right bundle branch. So it's taking longer for it to move down, but at the same time, there's another electrical signal that sort of comes after that. And that's why we see this R prime. So R represents the first R wave, and then R prime represents the second R wave that comes after the block is surpassed. That's why we get the bunny ear pattern.
I thought it was because the ventricles are depolarizing at different speeds. So the first R wave would be the unaffected ventricle, while the other R wave would be the affected ventricle by the block.
Right, that's what he's saying.
Yeah, basically, right? Because it's going past the block, depolarizing the ventricle, and then the other signal is coming back and then repolarizing it or depolarizing it again. So it's basically the same thing because the signal is going into the ventricle, right? Okay. But again, I don't know to what extent we need to know that. Just I would say be able to recognize the bunny ears first and foremost. There's going to be.
Is it usually in V1, the bunny ears?
It doesn't have to be, but it's, you know, most characteristically in V1. I think that's another reason why learning these things are so hard, because, you know, we can see manifestations of it in different leads.
In V2 as well, yeah.
Yeah.
So it's on lead 3. In lead 3, you can see it well.
Exactly. So in the precordial leads, how about that? Yeah. But especially V1, V2.
Where are the bunny? It's supposed to be negative, right?
If it's a right bundle branch block in V1, it's going to be positive.
Okay, that's the other characters.
Yeah, I have some more pictures coming up, but look for that. And then if we were to compare it to a left bundle branch block, we see how we have a very negative V1 here, plus V5, V6. Okay, I think Boards also talks about this. He does a pretty good job talking about it. But this is the slide that I really wanted to show because, you know, it emphasizes the major findings. So here we can really see the bunny ears here. We'll also see some characteristic changes in V5, V6 compared to a left bundle branch block. We see that the V1 is really low, right? Really negative. This is somewhat positive. If it's a really bad bundle branch block, this will be higher, right? So take home points, look to see what direction this is and look to see if you have bunny ears. I'm trying to make it as easy as possible. Okay. And
Justin, I wanted to ask,
yeah.
I was just confirming, like, I think I remember something about, like, if you see a QRS in one of the leads that's greater than 3 tiny squares, there's a bundle branch block somewhere.
Yeah, I don't know the exact numbers, but it sounds right. Yeah. Yeah. Again, I just look for pattern recognition, especially at this point here. But all right.
So sorry, the bunny ears, that's only for right? The left one doesn't really have that.
In V1. So I mean, to me, this looks sort of like bunny ears here.
Okay, that's fair.
But yeah, I just look at V1, and then if it's going upwards to any appreciable amount, compared to V1 for left bundle, that it's going downwards. Okay. Again, these things are going to look different. There's a lot of variation, and that's, again, part of the problem. But the more that you look at, the more you'll be able to recognize. So on that note, what do we have in the first one?
Right bundle branch block.
Okay, so what's the mean electrical axis?
It is. It's.
There is a
There is none. Oh no. AVF is
there's a left axis deviation.
It's kind of weird, right? So I threw this in here because to me, this is one exception. I always thought that the deviation would go towards the bundle branch block if there is one, but I guess it doesn't necessarily have to be. Typically, if we had a right bundle branch block, you would expect a right axis deviation, but this right over here is very, very weird. So I don't know what the heck is going on.
Yeah.
But the major thing here is that we have bunny ears here. Right?
You know, once you figure out which way all these leads point to, this whole picture makes so much more sense. If anyone's having trouble like figuring out what's going on, like for instance, you know, lead one goes from right to left, right? So that must mean the electrical activity is going right to left if lead one is positive. So that makes sense. So when you go down to AVF, the electricity should be moving downwards, but you don't see any activity. So that means it's not moving downwards. So you look at where is it moving towards, which way is positive. You see AVL is positive, that means it's moving to the left.
Yeah, before B5 and 6 are also positive, so it's like more confirmation about the left.
And 5 and 6 is for the left too, so it all makes sense.
Yeah, I'm glad you did that actually.
I just had that like epiphany moment right now that she was talking about.
Exactly, and that's going to happen, you know, but you have to think, like you said, what's going on in each particular lead with respect to a different part of the chest. So that's really good. This AVF, like I said, is kind of messed up because we would expect it to be...
Oh, because it should be moving towards it, right?
Right, exactly. So that's why I started off by talking about the depolarization. If you have a depolarization going towards you, then it's going to be up. So the positioning of AVF, if AVF is going to the floor, if you will, or to the feet, the signal is going that way, so you would see a positive deflection.
Right.
Yeah, I'm glad you brought that up. That's really good. But in terms of bundle branch blocks, we can all agree that we have a right bundle branch block here, right?
Yes, sir.
Yeah.
Okay.
Yeah.
And then, of course, what do we have here?
The left bundle branch.
Left bundle branch. One thing I did want to mention.
What the defining characteristics of that bottom one?
Wait, where's?
Sorry.
For the bottom one?
Yeah, like left bundle branch block.
Sure. So at this point, it's basically pattern recognition. So again, when you start to do a lot of these, you'll start to recognize. But to me, this looks nearly identical for the most part.
Yeah. What about V1, V2, and V3? Well, I guess V1 through V6. What about it is different than normal?
For left bundle, look at like B5, B6. You can see the two
V5
peaks
and
in the
V6.
R wave. Look how the R wave. It looks like it's kind of smooth, but it's supposed to be two different R peaks.
The first thing to give away bundle branch block is big QRS. Second thing to give it away is if it's to the left, like think about the precordial leads that are viewing the heart from the left side, which would be V5 and V6. You see how they're positive? That means that it's moving towards that side even more. So in order to go around the left bundle branch block, it like skips to the right and then boom, shoots to the left. And that's what gives you that big spike on the V5, V6.
Okay, so the way that you would determine this is you would say it's not normal because the QRS is too wide. So now I'm looking at the bundle branch and then I don't see bunny ears in V1. And also it's the depolarization is moving towards V6.
V5 and V6, which are the left side, so it's moving more towards the left, and that's why the V1, V2, V3, which are on the front and more towards the right of the heart, then you see them take a big negative dive down because the electrical activity is actually moving the other way right after it gets past the block.
Okay.
So once you know which way the leads are facing and what where it's moving, that's the easiest way to get this down.
Justin, could you zoom in on lead 1 and like that first R wave?
Can I what?
Can you zoom in on lead 1 and that first R wave from lead 1?
For the bottom EKG?
Yeah. So the first R wave to lead 1. Not V1, lead 1.
V1 or 1?
No, the first one, the very first one. Yeah, you can see like the first R wave. I think it's more than 3 tiny squares. So you don't even, just not even looking at the B6 cycle, you can just tell.
Yeah.
But Todd, you were correct. The first thing to look at is the QRS complex in terms of width. I should have mentioned that. But the wider the QRS complex, it implies that there's a delay in the conduction system between in the QRS complex, right? There's a delay in the conduction between the QRS complex.
Yeah.
And then you explained it very well with everything else. So. Again, I don't know if we need to know why the shapes are happening other than recognizing it. So that's that. We have another finding here. This is called multifocal atrial tachycardia. I'm including this because it was one of the cases that we went through. But basically, this has a very scary name. But if we break down what each of these words are, it's not actually that terrible. So the point is we have multifocal. So you could think of a focus is just an area that's not the SA node that's pacing the heart. So in the case of multifocal atrial tachycardia, we actually have multiple places, multiple foci in the atria that are pacing the heart. And it says here that they're all competing with one another. So what findings would we expect on the EKG? The findings that we would expect would be P waves that look all different, because now we don't have smooth P waves that are coming from the SA node. They're coming from all over the place. So we're going to see P waves that are, some of them are going to be wider, some of them are going to be skinnier. There could be, blips in the P waves, things like that. Okay, that's the multifocal atrial part. The tachycardia part just has to do with the rate. So we can very clearly see that this is a tachycardia, right? We can calculate it. That's what multifocal atrial tachycardia means. We have different P waves and we have tachycardia. It's really that easy, all right? This would be classified as an irregular rhythm, right? All the intervals are going to be completely irregular. Our intervals throughout are going to be completely irregular because
I had a question.
The SA node is not pacing the heart. Yeah.
So how would you tell the difference between this and like atrial fib? Because it kind of looks similar.
Good question. So here we actually have P waves, right?
You won't see them in, okay.
In AFib, if I go back, these are not P waves. These are fibrillatory patterns.
Oh,
okay. They look like P waves, but they're not.
Also, something very important she mentioned, because when this question popped up, I thought it was AFib, but if you could see the entire lead for this, and then you go to see the chest leads, B1 and whatever, you can see the clear P waves, while you cannot see that in AFib.
Okay.
Mm-hmm.
So Justin, another question I always have is, how can you tell if it's a P wave or a T wave? Like you see how that second arrow is pointing at that wave? I can't tell. I guess what Miguel said is actually where you would go to after, but like, is there a way you could do it when they just give you like one lead?
That's a good question. And I gotta admit that sometimes I struggle with that too. But I mean, maybe like find a really discernible P wave and trace it. So that would be a P wave, QRS, T, and then maybe there's a P wave there, and then QRS, and then T, and then P wave. You know what I'm saying? So I guess try to find one that you know for sure would be a P wave and then make your way through. But it's kind of tough sometimes. And sometimes you have the P waves on the T waves and things get really crazy.
T with the T and the Q and the O.
It gets nuts. It gets nuts. But I just decided to focus on, the more common type stuff. Nothing that's that super crazy. Okay. One thing I do have to say, if the pattern looks like this, but the heart rate is less than 100, it's called wandering atrial pacemaker. That's just something to memorize. If it looks like this, but less than 100, it's wandering atrial pacemaker. Because if it's less than 100, we no longer have tachy. Okay. All right, moving on to junctional escape rhythms. So a junctional escape rhythm is because there's a single place in the junction, the AV junction, that's actually pacing the heart. So we can tell if somewhere else besides the SA node is pacing the heart based on the heart rate, because we know the SA node fires at 60 to 100 BPM. If we have a rate that's 40 to 60, then it's going to be somewhere in this junctional location. We've already seen this, right? We've seen the upside down P waves. Basically what's happening here is we could have multiple foci if we have some crazy rhythm. But here it just looks like, maybe we have one. We have a retrograde depolarization moving back into the SA node. We've talked about that already. We can also have an accelerated junctional rhythm. So if the rhythm is between 60 to 100, and then we can actually have a junctional tachycardia as well if it's between 100 and 180. I don't know if we're going to need to necessarily know these. I just kind of threw this in for the concept of the junctional escape rhythm. It just means that the rhythm is being paced somewhere between the AV junction. Okay, so I don't know if anyone has anything to add to that, but that's just something else to identify.
And the negative P wave, sometimes you can just like not have a P wave at all, right?
Say it again.
Sometimes with junctional, you can just like not have a P wave at all and go straight into QRS.
Yeah, so that's a good point. Yeah, I've seen examples of that where you don't have any P waves at all. Basically what's happening there is that the backup pacemakers are firing to try to, escape the lack of activity from the SA node to try to generate something. Okay. All right, we'll talk about this now. We'll talk about the hypertrophies. So I know it says it here, but let's start. We'll skip the rate. What's the rhythm?
Regular?
Yeah, right? It looks pretty sinus to me. So just, I guess, get in the habit of saying sinus instead of regular, right? Because we see P waves. The P waves are pacing the heart. So that's good. And the axis?
One is negative, that's right.
Exactly. Right away we can tell that it's right axis deviation.
And ABR is positive.
Right. The characteristic finding of ventricular hypertrophy are these really big, skinny QRSs. Okay. I don't really know why they're skinny. I know why they're big is because there's a lot of muscle to depolarize. So that's going to increase the amplitude of that. Okay. A lot of times when people see this, they may think that this is characteristic, this ST depression is characteristic of ischemia, but it's not. It's actually part of what's called the strain pattern when you have a ventricular hypertrophy. So if you have these two findings together, it's probably not necessarily ischemia. It's more likely to be a ventricular hypertrophy. And one of the ways that we differentiate between right ventricular hypertrophy and left ventricular hypertrophy is where we see this in the precordial leads. So with right ventricular hypertrophy, we'll see this V2, V3. Here we have maybe a little bit in V4 compared to left. I should say it's positive, sorry. It's positive in V2, V3, V4. Whereas in left ventricular hypertrophy, it's going to be very negative. Okay.
Okay.
And
back to what you said.
Huh?
Back to what you said. I think they're thinner because the more voltage you have, the faster the electricity conducts through it.
Okay. So the reason why the directions are what they are just goes back to the positioning of the leads, right? So in V2, the electrical activity is moving away from V2, and that's because there's a huge ventricle that's depolarizing. So that's going to pick up a lot of electrical signal, and that's going to show negative, okay? The other way that we can confirm this is we have a left axis deviation, okay? So we have a positive lead 1, we have a negative AVF, we have a negative lead 2. That's going to tell us left axis deviations. We're going to have left ventricular hypertrophy. Okay. What else did I want to say? I think that's it for those. You see some ST stuff going on here, but that's still consistent with the so-called strain pattern. Okay. So the EKG is the kind of thing where you need to know what's going on in each of the leads, but you also need to be able to put it all together. So just because you see an ST depression somewhere, or you see a T wave inversion, or you see an ST elevation somewhere, doesn't necessarily mean that's what's going on, right? You have to put everything together. And as I said, you have to also put the clinical picture together as well. So remember we had that situation, I think it was the last case, where the patient came in and she had no symptoms whatsoever, and all the, the axes were messed up, the leads were placed wrong. So it's very unlikely if someone comes in with no symptoms and you see, this, it's probably not a heart attack.
So if it says hypertrophy and there's left axis deviation, so would that kind of mean that they have left ventricle hypertrophy, or could it just be either or?
Most of the time, again, I'm not an expert, but from the ones that I've seen, if you have left ventricular hypertrophy, you're probably going to have left axis deviation, although you don't necessarily have to. Okay.
And Miguel's explanation made sense. It's like the more muscle there is, the more the electricity is going to move through. So you kind of think of it shifting more towards the left because the left ventricle is bigger. So they'll shift the mean electrical axis towards that direction.
Yeah. Okay. Everybody good with that? Left ventricular and right ventricular. These are very easy to see on an EKG. When you see huge spikes like this, it's probably going to be hypertrophy. All right. I threw this in here because PVCs are pretty common. Also, PACs are pretty common. Basically, we're talking about the ectopic focus again. So this just means that another place is pacing the heart. So in the case of a PVC, this is basically like an early beat. So we see that this is pretty normal, this is pretty normal, and then out of nowhere, the ventricle just sends out a beat on its own. Okay. It can also be from the atria. I realize that this is kind of difficult to tell, but the major point here is we could have a PAC, we could have an ectopic beat that's coming from the atrium instead of the ventricle. This is a very characteristic pattern for a PVC, okay? Especially when you have the normal, and then out of nowhere you have that, and then things sort of get back to normal. I don't know if I mentioned it on the next slide. I think I do, but if not, I'll mention it here. You'll notice that there's a bit of a delay here, and this is a compensatory mechanism. This allows the ventricle to relax, okay? Yeah, compensatory pause, okay? So normal, 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 or sinus, I guess I should say, sinus, 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 and then boom, PVC, and then a pause. And this again prevents the tetany of the heart. So this has to do with the refractory periods and all that stuff I'm not going to talk about. But then realize things get back to sinus. So these are when people feel palpitations, right? Questions on that? Okay. Now we get into the ST segment changes. So we have to differentiate, I think we already did, but ischemia versus infarction. But just to say it again, ischemia just means a particular area is not getting blood and therefore oxygen. And of course, there's a very small window of time before we have permanent death of the tissue. When we have ischemia going on, we see inverted T waves. We could also see peaked T waves. And also, very importantly, we see depressed ST segment elevations, okay? When we see infarction, this is, if we're having a STEMI, right, a ST elevated myocardial infarction, we're going to see ST elevation here. Okay. Yeah, okay, good. I do mention it. So this was from her lecture. She was basically saying how you can have different patterns of ST segment depression. I think she mentioned that if you get an EKG and you see a down-sloping ST segment, this indicates the worst prognosis versus the horizontal and the upsloping. But again, this is just pattern recognition, especially at our point. And then compare that to ST elevation. This is very clear, right? Sometimes you can change the J point. Right? That's the connection between the QRS and the ST. So that J point could be elevated. But yeah, this is just emphasizing the difference between the different types of ST elevation. You can also have inverted T waves, which is representative again of some sort of ischemia leading to infarct. Okay. What I really want to emphasize again is this slide, because we need to know what's going on where. And very importantly, we shouldn't really be so quick to diagnose a STEMI unless we have reciprocal changes in the opposite leads. So if we're talking about an inferior infarction, we're talking about leads 2, 3 in AVF. The reciprocal leads are going to be 1 in AVL. I'm pretty terrible with direction, so I'm just going to flat out memorize these. I'm not going to try to figure out what's the opposite of what. If you guys want to do that, you can. But that's there for that. All right. So what do we have in the first one? You guys want to go through
the elevation?
Okay. Do you guys want to go through rate, rhythm, all that?
It looks like hypertrophy.
Not really.
Well, yeah, we could do the rate rhythm.
Okay. So somebody tell me the rate.
It's normal.
Like a little bit above 75.
Yeah, that's cool. That's fine with me. And then the rhythm?
Normal.
It's regular sinus.
Sinus, right? Okay. Electrical axis?
There's a P wave for every QRS, so that's good. Oh, axis, sorry.
Axis.
Yeah, whatever. Just shout out whatever.
I don't see a deviation, so no.
There's an infarct on the left side.
Okay, yeah, we'll get to that. But yeah, the deviation, it's kind of hard. This is one of those in-betweeners, but you know, using the method that they showed us, it looks pretty normal to me. So we can just cut it there. But yeah, somebody talked about the infarction. So where's the infarction?
Left side of the heart.
So
from the left circumflex.
What leads?
One.
So we see leads 1. We see the ST there. ABL as well.
Okay.
And also, if you see B5, B6.
Yep.
And then you see the opposite in FBF. You see depression as well as ABR.
I think 2 and 3 have depression too. 3 is like
Yeah.
really.
Yeah. So that was good. So again, right here we have ST elevation. Right here we have ST elevation, and then here this is ST elevation. I think. Yeah.
I almost confused lead 1 for the ears thing, but then I recognized that the second wave was the T wave, not a second R wave.
Yeah, exactly. There might be some hypertrophy here as well. We don't know. She could have had some previous hypertrophy. I mean, these QRSs here are pretty big. So I think someone said hypertrophy. So I would probably say some ventricular hypertrophy, left ventricular hypertrophy here.
So we're saying this is left-sided infarction?
Yeah, this would be a lateral
right-sided?
lateral MI. So I think, Miguel, did you say left circumflex?
Yeah.
Yeah, that would be the
So the ST elevation is going to be on the side, like on the leads that are on the side of the infarction.
Yeah, so that's why
Like
this
V5,
slide is
V6.
very, very important. So we were talking about a lateral MI. So in our patient here, we have a ST elevation in 1 AVL, V5 and V6. So that corresponds with the left circumflex artery, which is going to be the lateral aspect here. Clinically, this is very important, right? Because if someone's having an MI, you need to know which vessel to get into. So if you don't want to flat out memorize these, you can think of, again, where the leads are going. So we know that lead 1 is going from right to left. So, you know, the positive point is going to be lateral. Same thing with AVL. And then V5, V6, based on the placement of the precordial leads, we're talking like somewhere over here. So that's lateral. I'm not going to go through all of them, just as an example, right? That helps.
Yeah. So would you say the infarct, the leads point towards the infarct? So if it's pointed positive, then that's the way we should.
Yeah. What about the bottom one? Forget about the infarction. We know there's an infarction. Tell me rate, rhythm, all that.
Normal rate is it's below 100 and between 175.
What else are you looking for? Yeah, it's a normal rate.
Yeah.
Rhythms, normal.
Latin fart.
Regular.
Okay.
2 and 3 have a elevated J point.
Do we have a P?
AVF as well.
I don't see a
No
P wave.
Oh yeah, I don't see P waves.
Yeah. It's kind of hard to tell.
They're kind of there. Like V3 has some.
Yeah.
And lead 1 also has some.
Yeah. They're kind of hard.
You can kind of see it in V3.
Mm-hmm.
They're very subtle. The thing is that they all record the same thing. So if you don't see them in like lead 1, but if you see them in a chest lead, they're there.
I don't see them in V3. I only see T waves.
Yeah.
Well, look after the T. It's like a very like subtle elevation
I
thing.
don't see any P waves.
That might be one. I don't know.
Like, it's super subtle though.
AFib that led to like LA. Or
it could be.
But
I mean, look at
AFib
before. Look at before. The second, almost the last before the last QRS. Super subtle, right? Kind of there. I don't know.
I've never seen. So is it,
Or the one below it, B5, the last QRS. It's just.
Bro, if you're gonna
very
go looking
subtle.
for it, then it's probably not there. As they said.
Kind of hard to tell. We're not experts, so who the hell knows? But more importantly, what do we have going on?
Also, wait. Sorry. Lastly, since the rate is like almost 75, that's like at the rate of the SA node as well.
Steph, I think Steph had a question.
Yep.
I'm just gonna wait until everyone finishes. Okay, so is AFib the only thing that doesn't have P waves?
You can have VFib.
Right, but those are all irregular rhythms, right?
We're talking about in this case, right?
Or just any case that would have a regular rhythm with no P wave. Is there really any pathologies that have that? Because then you could just assume there's a P wave and not like it's kind of subtle, but like if you know that there's no P waves are associated with something that's irregular, then you don't see that here, then you could just not waste your time. And
that's a pretty fair point. Yep. I can't think of anything aside from the AFib, the VFib, things like that.
I think Dr. Sizemore pointed out something in her notes. I'm just trying to find it in my notes, but there was, yeah, I can't find it. If I find it, I'll let you know stuff. But I think there was something else, but it's like very, very rare to not have P waves.
Can you have like an infarct that affects the node itself and then any P waves?
You said, can you have an infarct that affects the node, and then that's...
And then you wouldn't get the P waves?
Well, where's the MI occurring in this patient?
Inferiorly.
2, 3.
That's a really good point.
The RCA.
So right coronary.
Yeah, so it could be, right? Because the RCA does supply the...
Yeah,
that's a really good point. So it's very possible.
Wait, this isn't the left anterior descending?
No, because this is an inferior.
Oh.
This is 2, right? 2, 3, and AVF.
And AVF. Oh, I see.
So that's going to be inferior.
I was looking at V5 and V6 for some reason.
Yeah, aren't V5 and V6 also elevated? So it's like a lateral inferior infarct.
Yeah, but that'll be.
I don't think there are as much as 2, 3. 2, 3 AVF are really elevated.
That'll still be the posterior descending artery.
That's pretty good.
Kind of anything from the back is going to be PDA, even if it's like it's left or to the right.
Okay. Yeah, I mean, it's possible there's multiple vessels, but I mean, this definitely stands out. So that's really what I was getting at here. All right. So I think we're all pretty good at ST elevations. All right. Just let's see what else do I have. I think this is the last one here in terms of actual concepts. This again is just recognition. So I mentioned before hyperkalemia when you see peak T waves like this, it's a sign of hyperkalemia. If you see shallow T waves, if they're, basically the opposite of that, then it's hypokalemia. You can also see changes, as I mentioned, with the QT interval. So hypocalcemia lengthens the QT interval, and then hypercalcemia shortens the QT interval. So that's just flat out memorizing. I can't really say anything else about that. There's other changes, I'm sure, but just be able to recognize those. You guys ready for the final exam?
Man.
So we got
that. Holy shit.
So tell me rate, rhythm.
Yo, this thing
rate is normal, right?
My eyes hurt.
Yeah, that's probably the only thing that
my eyes hurt. Yeah, so is it right on the branch block here?
Okay, that's one thing.
There's some irregularity as well. I see there's like, oh no, that's when it starts. Never mind.
The rhythm's irregular, right?
It's
No,
what?
Regularly irregular.
There's ST elevations in 2 and 3. The ST is actually taller than the QRS complex.
Yeah.
There's also an escape rhythm here. There's also an escape.
Something's dropped.
Okay.
Yeah, look at B1 and B5. There's like a big pause in the middle, and then another rhythm took over because you see different.
They shocked the guy.
Holy fuck!
There's a lot. So this to me looks like a PVC.
He's got them all, Justin.
Everything that I just talked about, he's got.
Man,
is he even alive?
So somebody mentioned the bundle branch, right? Right bundle branch block. That's here. This looks like a PVC. Of course, we have the STEMI. Where's the STEMI?
2-3 AVF.
So what location is that?
Inferior.
Inferior. Good. And what artery is that probably?
RCA.
RCA.
Yeah. We can go finding the reciprocal changes. They're there.
Wait, it's not the PDA inferior?
Inferior is RCA.
Oh, what's PDA?
Yeah, because it gives off the other little branches.
There is no PDA.
There's PDA, yeah.
Yeah, PDA. I thought the
that's
RCA
posterior
would be the
descending.
PDA. Oh, yeah, that's right. That's just saying that, like, usually it's stuck so high up in the PDA that it's the right coronary artery. It's not really the PDA that's affected. Okay, sorry. Go
on. You guys see anything else? As if there wasn't enough already.
What about those like huge like lines? Or is that hyperkalemia?
Where?
Yeah, like right there. What is that?
That's like a ventricular followed by another ventricle thing.
Or is that hypertrophy?
And then I'll pause.
Yeah. Why are the ST waves so tall? Like even for an ST elevation, they're like bigger than the QRS complexes. What would make that happen?
Maybe a massive.
Wait, is this a ventricular skip? Never mind. Is that a ventricular skip rhythm?
It could be hypertrophy.
Yeah, because it's just ventricle after ventricle.
Is that you said the ventricle sometimes just sets its own thing? Like when you look at V5 at the bottom, like after the tall wave in the middle, there's a compensatory pause. So is that the ventricle setting its own thing?
Very nice.
So there are P waves in front of it.
That's why I thought this was a PVC, because you're right. There's a compensatory pause, right? And here we see compensatory pauses. So yeah, that's what's
okay.
Yeah, like V5 has that too, right? And like after the tall pause. Yep.
Yeah, dude.
No, like at the very bottom too. Like that's even clearer.
V5 or V?
Yeah, like the bottom strip, the very last one.
Oh, you're talking about the rhythm strip? Yeah, definitely.
Yeah.
I mean, there's a bunch of them, right? We have one.
Yeah,
here.
like that one.
We have one here. We have one here. Yeah, awesome.
One time I was working in we took some guy to the ER while I was in the ambulance, and then the paramedic was like, "Oh, he's throwing a lot of PVCs, so there's a very, very high chance for MI. So maybe that's like he's having a myocardial infarction, and the PVCs were probably there before. So I think PVCs and MI should go like hand in hand."
There you go. All right. So I put the answer key here, or whatever, the printout. And yeah, we nailed it. Good job. So sinus rhythm with frequent PVCs, right bundle branch block, marked ST elevation, consider inferior injury, acute MI. I think someone said about 75, so that's good. And then you can see.
Did they make it?
I have no idea. I just found this picture on Google.
Did you just try to find like the most possible messed up one?
Not intentionally. I Googled STEMI, and this is what came up, and it was too good not to have.
Yeah, that was sweet. Yo, thanks, Justin, man. Really appreciate it. Thanks for taking the time.
Thanks, Justin.
Yeah,
Thanks,
thanks,
bro.
Thank you.
No problem.
Student
Are
of
you
the
good?
month.
Are you,
Justin, what's your Venmo?
right?
I'm gonna send you a beer, bro.
All right.
What's your Venmo, bro?
You gonna put this recording up on the drive or something?
Yeah, I gotta
Or
figure
somewhere?
that out. It's gonna upload it to the cloud, and then I guess I could save it and upload it from there. But
Send it to the course directors, man. Let them put in the flexion.
Could you also like upload the slides too?
the slides should be up
Slides
there.
are there.
Oh, I didn't know that.
Yeah, they're on the CR folder. So I'm gonna go ahead and stop the recording. But I really hope that it was helpful, guys.
Dude, it was
you.
very helpful.
Thanks,
Thank
Justin.
you.
Thank you.
Thank you.
No problem.
Thank
Appreciate
you.
it.
Sure.
Thank you,
Bye,
Justin.
yo. Take care, everybody.
Bye.
Love you, Justin.
Wait, Justin, before you go, are you still there?
Yeah, Justin. Thanks,
Yeah,
dude.
just what was the difference between the what's it called, the PD and PAD?
The what?
When the ventricle fires on its own.
Oh, PVC?
Oh yeah, PVC and PAD or PAC.
PAC and PVC. So a PAC is that the atrium is firing on its own, and then a PVC is that the ventricle is firing on its own.
Oh, okay. So you'll just see the P wave before, like, and then you'll see like a compensatory period. Okay.
Exactly.
Okay.
It was kind of hard to tell here, but
Okay.
I guess
Yeah, that's what I
missed
missed.
a little bit better, but I figured you guys would be able to catch it, right? With the compensatory.
All right.
pause.
Yeah. Perfect. Thanks.
All right, man.
See ya.
Bye.
Sup?
So
Look at you. Look at you.
be honest, was it helpful?
Amazing. I am so pissed that I missed the first like 15 20 minutes, I think. But damn, man. Like it's a good thing I kind of like just from the CBL I got a little bit, just enough to kind of get, like, I guess I missed the first 20 minutes, but it was enough. I knew a little bit. But after that, dude, that was amazing.
Thanks.
After that, you need a letter of recommendation for your cardiology fellowship. I'm gonna write you one.
Thanks, man. I appreciate that. It means a lot.
Just write your own. Like, or get a patient evaluation. Be like, my patients say I'm a good cardiologist, so I think I should finally get a degree and that says I can practice legally.
Yeah.
I
Forget
think
all
you're
this
still
stuff,
recording,
man.
Justin.
What's that?
I think you're still recording.
You are still recording.
Oh, I could stop recording. It didn't.